Welcome back to another episode of Fertility, Hormones and Hope, the podcast where we bring you experts within the fertility and women's health space to answer your most asked questions and help bridge the gap between holistic care and evidence-based science. I'm Richa Puri, a nutritional therapist and a prescribing pharmacist specialising in women's health and fertility.
And I'm Jen Walpole, a BANT registered nutritionist, also specialising in fertility and pregnancy nutrition. And we're absolutely thrilled today to be joined by Professor Tet Yap, who's a consultant andrological surgeon at Guy's and St Thomas's Hospital and a professor of urology and andrology at King's College London. He specialises in complex andrology, male fertility, sexual dysfunction, including andrological care for cancer patients. He also runs his own private practice in London, where he provides thorough assessments and investigations to support his male patients.
Professor Yap is an internationally renowned leader in male fertility and continues to lead research within this area. He treats and supports male clients that have azoospermia, low sperm count, sperm retrieval, microdissection, sperm extraction, varicocele treatment, vasectomy reversal, and sperm freezing. Jen and I have seen firsthand the positive impact of Professor Yap's input and approach with our male fertility clients and feel very privileged to work closely with him in optimising their outcomes. And if that didn't keep him busy enough, Professor Yap is also the founder, editorial director and executive director of Glass magazine, a magazine focusing on sustainable luxury, art and culture. So we're going to dive straight in, Professor Yap. So we wanted to go back to the basics. So the NICE guidance or the NICE guidelines. So NICE is the National Institute for Clinical Excellence. So what does NICE state when it comes to male fertility?
Yeah, this is a good question because NICE have just actually come out with their new fertility guidelines at the end of March this year. The previous iteration was in 2013, so that's 13 years gap. Quite a few things have changed. Now the male partner gets more of a focus as well, which is important. So it says that when couples have been trying for a year without any success, they should get a joint assessment, which is very important. And there are some caveats to that. One of the caveats is that if the female partner is above 36, for example, or on the male side, there are some issues that could result in fertility failure. So things like clinical varicoceles, things like scrotal surgery, things like testicular cancer, then it should be even sooner than a year for assessment, which is sensible. They've also added a few things that were a bit different from before. One of the key things is the assessment, how to assess the male. So they've now mentioned that varicoceles are an important part of this assessment to try and diagnose and treat this in couples where they have normal semen parameters and infertility. And one should also think about hormonal assessment as well. So this, believe it or not, is a big step for male fertility. It is obviously something that we've known for quite a while, but we've been advocating on the male side for NICE to include this in the guidelines for all this time, for over a decade, written papers to support this. So this is a step in the right direction. For at least for the male side, which has often been ignored in this process.
Yeah. So just to state, so the NICE guidelines are what sort of doctors and clinicians follow when it comes to assessment, diagnosis, referral. And so if a patient was to go and see their GP, the GP would then refer to the NICE guidelines to see what the next steps would be?
That's right. The first stage of guidance. So it's useful for GPs. I think NICE guidelines are useful as a guide. And that's why they're called guidelines.
That's why they're guidelines.
But when you're dealing with complex fertility cases like myself, oftentimes we provide evidence for the guidelines, and we might do things that are evidence-based, but are not yet in the guidelines.
Yeah.
Because it takes quite a long time, doesn't it, for those changes? Like you said, it's been quite some time before this update happened.
Yes. For years, Varicoceles, for example, were not in the picture.
included.
In fact, it was a nice guidance against treatment of Varicoceles in the 2013 iteration. So
really interesting, because I had a client that I referred to you, and it was picked up in the NHS that he had these Varicoceles, and they were quite big.
Yes.
And it was just kind of, go on, do your IVF.
Yeah.
And obviously it's only when that then failed that then obviously they come to someone like myself or Reacher, and then we've then made that link and referred them on to you. And I think it's really important. But this is brilliant, because obviously going forward, it'll be hopefully a bit more straightforward for people.
Yes. Yeah, there's some other things that they mentioned that are slightly different, but these are the key points.
So previously, they wouldn't have been even offered a hormonal blood test assessment?
That wasn't part of the NICE guidelines. So it was just a semen analysis. That's it. But now the NICE guidelines have been quite clear about repeating a semen analysis, in 3 months' time. But also to not wait for 3 months if it's a really severe issue, like if it's no sperm in the ejaculate, for example, Azoospermia. Don't have to wait 3 months. You need to do it pretty soon
Straight
and then
away.
get moving with investigations.
But it's difficult to then know if that is the case, isn't it? But like you're saying now, if there is a presentation of a couple and the female is over the age of 36, is that right?
No. If the female's over the age of 36, then you shouldn't be waiting for a year even, if they've been having trouble trying to conceive.
So they can get their assessments a lot sooner now.
Okay,
so that's a positive step in the right direction as well.
Yeah. At some point in the past, it was 2 years. So, it's changed a lot. So,
and can I just quickly ask, so bloods then via a GP for men, is that something they should be pushing for? Is it kind of backed up by the NICE guidelines, so they shouldn't be refusing?
That's a good question, and I think we see this sometimes, isn't it, as pushback when we say, can you get your GP to do these bloods? Well, not the NICE guidelines have clearly stated that, yes, this should be part of the assessment. So
that's really important, really important, because we see it getting pushed back a lot, actually. Particularly on the male side. But that's brilliant.
Yeah, for Jen and I, we're also, wanting to do kind of nutrient levels like folate and vitamin D and B12, and looking at things like inflammation, so a CRP or an ESR, for example.
And hormones, unless they come.
No, but that's what I was going to say. So at least if we can get those basic hormones done, that's a really good, again, step in the right direction.
Sometimes those hormone bloods as well are the first point when we're seeing, elevated FSH, elevated LH, and a semen analysis that's a little bit off. And that might be the point when we, again, send someone to you. So it's important to look at this.
And does NICE then state which bloods within that hormone profile?
They mention gonadotropins, so FSH, LH,
yeah.
and testosterone, yeah.
So semen analysis, I know we've talked about it a little bit, we've just mentioned it. What should that comprehensive semen analysis include? And are some of those markers more relevant than others?
Well, a great question. So semen analysis, the parameters for semen analysis were really established by WHO. So they looked at thousands of couples around the world, and there have been a few iterations. So the latest iterations from 2021, and the previous one before that is 2010. So the key points about semen analysis are things like count, amount of sperm, concentration, so amount of sperm per mil, motility, so amount of moving sperm, especially progressive motility, moving fast and forward. And there's also morphology, which I'm sure we'll talk about in more depth. And there are also things like volume, pH, And very detailed semen analysis will look at things like round cells as well, which could be markers of infection or inflammation, but not directly. So there are all these different things that are part of a semen analysis. I would say there's not one parameter that's most important. You need to see it in its entirety. And also there are things around the semen analysis, like the abstinence period. Did you collect everything in the bottle? Was the patient well when they did the semen analysis? All these things have to be taken into account when assessing the semen parameters. So back to your question, what's the most important? As I said, there's not one marker that's most important. You need to look at it all. But if I were to choose a marker, it's probably something called total motile sperm count, so which looks at concentration, volume, and motility. So these three things. Yeah.
Okay, that's really interesting. And I know we've had a conversation about this before, just the validity of the morphology. Can you just explain to our listeners why you don't want to just pin everything on that? Because I think I often get this question where, my partner's count and concentration, everything was looking good, but then the morphology is 2% or 3%, it's a little bit on the low side. So can you just explain that a little bit for us?
Yeah, of course. Well, guys, morphology is the most overinterpreted semen parameter. There is a relationship, but it's probably the weakest predictor out of all the ones that are said in terms of fertility. I mean, if you have no sperm, if you have zero concentration, you can't get pregnant. If you have no motility at all, and there is something called vitality, which is amount of live sperm, also important in the parameters. If you don't have vitality, if you don't have live sperm, you can't get pregnant. But with 0% morphology, 20-30% of couples still get pregnant. Then that's with zero.
That's really interesting.
Yeah, one of the issues is that morphology is a scientific criteria. We use a strict criteria, something called Kruger's criteria, which looks at 4 parts of the sperm shape to determine morphology. But how many sperm we actually look at to determine this morphology? We look at 200 sperm. And most men have millions of sperm.
Yeah.
Okay, so that in itself, the fact that it is slightly operator dependent, because we have to look at, how big the head is, and what's looking at the tail like, and things like that. That's going to cause variation, and indeed there is variation. There's about 80% variation when you're assessing morphology between different individuals.
Wow.
Whereas with motility, it's less than 15%.
Okay.
And add to that, we only look at 200 sperm. It's not going to be, as accurate a predictor. Okay, but it is a predictor, and it basically helps us investigate the male a bit deeper. Okay, because it can lead to more in-depth testing. And I think you will be talking later on about sperm DNA fermentation and things like that. So it might uncover other issues. It's useful as a marker, but has to be taken in the context of all the other markers. So morphology alone is a very weak marker. You can get pregnant with low morphology, but morphology in combination with a low count, a low motility, that's significant.
So that's when you would then do further testing?
I would do testing with low morphology, but I would reassure the couple when I'm doing that, saying, please don't worry,
It's just a check.
This is more a check rather than, a deep investigation of big problems, which you do have to do with low sperm counts and things like that, because they often are a marker of something else going on in the body.
And if morphology is low, but the other parameters are okay, and you're saying that there is a chance for pregnancy, are they then generally viable pregnancies?
Yeah. No, absolutely.
Okay.
Absolutely. We see this. I'm sure you have the same. We see patients being investigated for low morphology and they get pregnant and then they tell us, okay, everything's fine. I don't see that so much with, very low motility, for example.
Okay.
I see that sometimes with a low sperm count, but but low morphology constantly they are getting through that issue. But it's useful. It is useful, and one of the things it's useful for, especially in the past, was because the male never got investigated. So morphology was a gateway to further investigation of the male, and it spurred us to have more accurate, more in-depth testing for the male side. So things like DNA fragmentation, which is just starting to become, an interesting and a more accurate test. The evidence is not there yet for a few reasons, and I think it's because we've had less accurate tests in the past, and it's the way the tests are applied, for example. But I'm sure that's a topic of another podcast. So it's a gateway to understanding male fertility, but you don't have to have perfect morphology to become pregnant.
That's really reassuring, because I think for a long time people have been sort of hyper fixated on the morphology, and if that's not good, then they generally assume that the overall picture isn't good.
That's
so
it.
So it's really understanding the context of that.
In terms of as a severity marker, it is the least. It is a marker, like I said, but I think a lot of people focus on morphology, and when they've done everything, the morphology doesn't change. It becomes frustrating, and actually sometimes it doesn't change. But your DNA fragmentation, for example, will improve tremendously. And we see this quite a lot. It's actually a topic of future research.
That's really interesting. And Richa and I have seen firsthand, obviously, the positive impacts that diet and lifestyle changes can really, really make to some of these semen parameters, as well as the DNA fragmentation, which you've mentioned. I know you've mentioned kind of, how well someone is when they do the analysis. What other factors can impact the semen analysis or particular markers, with the count? And I mean, it's probably quite different for some of those different markers, but just some of these factors that we want to think about.
Yeah, so in essence, you're asking about male fertility, right? What causes male infertility, which is another great question, because we often don't think about it in depth. But one way to think about it that's quite interesting, and I teach my students how to try and frame male fertility, is that's either a difficulty or a failure in sperm production or sperm delivery. Okay, so if it's a production issue, it could be genetic, it could be hormonal, it could be lifestyle, smoking, and that's where fertility nutrition is really are so important. It could be due to anatomic issues like varicoceles, one of the most common causes. It could be due to infection, inflammation. It could be due to drugs, and we shouldn't forget this, especially testosterone therapy, steroids, things like that, as well as the more conventional like chemotherapeutic drugs. They can affect fertility. But in terms of sperm delivery, you can think of it as coital problems, so ejaculation, erection problems, penile curvature. That's what we as andrologists take care of. And also an obstructive, a functional issue. So that can be, again, due to infection. Infections can cause obstruction. You can get an anatomic obstruction that you were born with. It can be genetic, for example, cystic fibrosis, where you don't form the vast tubes that transport sperm from a testicle to the urethra. So all these things, but that's how we think about what affects male fertility. In terms of specific parameters like motility and things like that, I always think in terms of the production side, especially. Obviously, the delivery side is important, but the production side has a lot to play with. And those are a lot of times, except the genetic issues, modifiable. Okay. For morphology, I think research in the future will probably link it to oxidative stress and perhaps fragmentation as well, because there are a lot of things that we see that do help with morphology, for example, lifestyle changes, for example, hormonal changes affect oxidative stress. So that's something, again, part of our very active research that's happening.
If someone does present to you with male infertility and you've done your assessment, what would then be your medical approach for treating some of these issues? So some of the things that you've just mentioned there. So, for example, to increase testosterone or to reduce prolactin or treat the infection. So how would you decide, which treatment is most appropriate?
So a male fertility assessment should be quite in-depth by the time they reach us. It's not just a simple screen. So we look for varicoceles, and that can be treated relatively easily. There are two ways to treat a varicocele in broad terms. You can either do surgery, and the gold standard for surgery is microsurgery. So under a microscope, you tie the veins off. And varicoceles, just to explain to anyone who doesn't know what varicoceles are, they are big veins, and they're dilated veins essentially that lie around and on top of the testicle. So these are your testicular veins that drain your testis of venous blood and goes all the way to the heart eventually. So all these veins form something called a pampiniform plexus, which is this group of veins over and on top of the testicle. And in varicoceles, the pathology is these veins are leaky, essentially like varicose veins in the leg. Yeah. So basically they stretch and they bring back blood that they're supposed to propel in one direction back to the testicle, and they heat up the testicle. They also bring back all the waste products that your testicle has been producing. They're trying to get rid of it, and it's going back into the testicle. And because of that, you have a heat effect, you have a metabolic effect, and that can damage sperm through different mechanisms. So varicoceles are interesting because they're very common. So 15-20% of men have varicoceles. I have one myself. And they are the major cause of male infertility issues. 30% to 40% of primary male infertility, and about 40 to 80% of secondary infertility. So you've had a child once and then you find it difficult to have a child again, are caused by varicoceles alone.
That's a high percentage
huge numbers,
of men, isn't it?
Huge numbers, and it's easily treatable. One of the reasons for this is that varicoceles get more severe, or the impact on sperm gets more severe as we get older. Probably because these veins stretch and get bigger, much like varicose veins in your leg. You get more prominent as we get older. It's exactly the same. Okay, so we see this a lot in secondary infertility, and it's something, as I mentioned, that's easy to reverse, and I'm glad the NICE guidelines have.
So I was just going to say it's good now that the NICE guidelines have mentioned it and stated it.
Yeah, exactly. So varicoceles, there's a lot of research going into should we be detecting varicoceles earlier? What kind of damage does it cause early on that we can say, oh gosh, that's something that's happening already? And that's where the advanced tests like DNA fragmentation could be useful. Okay, they might be able to predict early varicocele damage, for example. So that's again, research that's moving forward in the field. But for now, definitely if varicoceles cause abnormal basic semen parameters, they should be treated.
And so they impact the semen parameters as well as, I know you mentioned the DNA fragmentation there as well. And I think it's a really important point to just labour that increased risk up to 80% in secondary infertility. Because I experienced secondary infertility, and I have a lot of followers that are also experiencing secondary infertility, and there's a lot of blame, self-blame, and the woman feeling like it's something they did, they're stretched as a mum and juggling and all of this sort of thing. when actually we need to still, even in secondary infertility, we shouldn't be saying, well, you fathered one child or two children.
That's right.
We need to investigate this.
For the male side, it's 80%. So it is really, really something to think about, And just to mention again that varicoceles need to be clinical as well to have an impact when treated. So you can have radiological varicoceles in that they detect an ultrasound, but you can't feel it. And these are usually very small varicoceles.
Yeah, I was just going to ask. Yeah. So if a man or a male was doing a self-assessment at home, they wouldn't be able to then pick it up themselves.
Usually they can, but they probably don't know that it's a varicocele. Okay. They probably don't know it's varicocele, because whenever I examine in clinic and I detect a varicocele, I get them to feel it and they go, oh, okay, so that's what it is.
Now I know, what that is, yeah.
And they often have a history of discomfort. Like a lot of men, like 1 in 5 of us. I mean, I had for ages. I thought, what's this achy thing when playing sports?
And do you mind me saying, were you quite young when?
Yes. I was quite young. In fact, because I'm quite old now, so my fertility journey is done.
Yeah.
And I had my children very young, which was I was quite lucky in a way, because my varicocele grew with age, and it's interesting because I find it more and more difficult to have my children going down the line. Although I was young, so I have 4, and every time it took longer and longer and longer, and the last one took there's a 10-year gap. And I think we're just quite lucky in that, because I'm pretty sure it's a male factor from my side, because my varicocele is quite significant, and nobody picked it up. It's only because I am in this field. When I first presented, as a mere medical student, or just after medical school, and we were trying and didn't have any luck. I didn't even get offered a semen analysis, so that's how we were told to just crack on, basically. It's just been a year, it's fine. So never picked up. It's only when I started doing fertility work in training, and that's the other thing. Male fertility is not really taught at all in medical school.
There's a lot really of gaps, unfortunately, isn't
there? Maybe you see it once, but you have all the other things to learn, and so it becomes quite a footnote in your medical education for most people.
In terms of, I know we've mentioned the NICE guidelines, and they should be potentially picking up that there's a varicocele. Would that mean that someone then qualifies for treatment within the NHS, or is it still, is that having to be referred out for private?
No, varicoceles should be, if you're picking up in the course of NHS fertility or even private fertility assessments, you can have it treated on the NHS. So I didn't mention the other treatment. So microsurgery and X-ray or radiological method, which is basically called an embolization, where you block the main vein that all these veins drain into. The main vein is somewhere in the back, so you basically block it with some coils and some glue. And actually, that is probably what most people use, because it's easy. It's relatively quick, compared to surgery. Surgery is about an hour, microsurgery, for example, whereas embolization can be 15-20 minutes under local as opposed to a general. And you don't get a big, you don't get a cut. It's not a big cut anyway, microsurgery, but it's an even smaller incision where they insert the wire to thread these coils, and it's a little incision done by the radiologist, either in your groin or up here where your biggest superficial veins are. Whenever I describe it, men do turn a bit pale.
Yeah, I've had a few patients who have been really worried, but actually it's such a straightforward procedure, and you do it so many times. It's something that they should hopefully not be too concerned.
Completely. I tell them, I would do one microsurgery a week, whereas my radiology colleagues in comparison would do about 10 or 15 embolizations, the ones that we use, for example. So they're very busy, compared to us. Interestingly, microsurgery is geography dependent. So certain countries do a bit more microsurgery than embolization.
Okay.
There are a few reasons for this, which I won't go into, but I would say embolization is usually the first port of call here in the UK.
Yeah, that's really good to know that people can try and push for that via the NHS. Is that a recent thing with the NICE guidelines updating, or has it always been the case?
It's always been the case. I think it's more
It's just a
diagnosing
matter
the
of picking it up,
varicocele.
isn't it, in the first place? Yeah.
Yeah.
And then what's the success rate then for if they do have a procedure?
Oh, very high. So about 70% of men will have improved semen parameters. Not all men. You know, sometimes you pick it up a bit too late. So it's more about stopping the decline, you know, and trying to get to the level where the damage baselines, you know, rather than keeps going down, because you can go down to zero, you know, with some big varicoceles, your sperm count can go down to Azoospermia.
So it can have quite an impact.
Huge impact, yeah. So once you get to that stage, only less than 1 in 5 men start producing sperm again once you treat the varicocele, whereas 60-70% of men will respond with better semen parameters if you treat it before it gets to that stage.
So it's really worth having that assessment and establishing whether there is a varicocele.
That's right.
And then going on to have treatment, and then hopefully, you know, better outcomes with their fertility journeys then as well.
Yes.
Yeah.
So the whole thing of varicoceles is now early detection, and perhaps in the future you might start to screen for them. You know, if you have varicocele, instantly do a sperm test, you know, at that age. Because sometimes the damage might be already occurring when you're in your early adulthood, you know. Because the other thing that varicoceles cause is discomfort, this dull dragging sensation that I mentioned.
Yeah, and is there an association with back pain as well?
You can get back pain. It's mostly scrotal discomfort, but sometimes you get loin pain, back pain, groin pain because of it.
So if any patients have got any of those symptoms, then they should really just go to their GP and have an assessment, really.
Especially if there's a fertility context as well. Yeah.
We're often picking up groin pain, and, you know, when we do our case taking with clients, it's something, it's a bit of a red flag for me to then again send them to someone like yourself for investigating.
The classic description of varicocele pain is a dull, dragging sensation in the scrotum that's worse as it gets through the day. As you get through the day, because essentially walking around, you're pumping blood back into these veins, and these veins are stretching, getting bigger. So, so that's the classic symptom.
Yeah, that's really interesting. You mentioned as well about those veins, like with the toxins and, or, you know, waste products are kind of then it's eliminating them. So do you see an increased risk with infections with varicoceles?
Not directly.
No,
but they can coexist though. So looking for infections is an important part of male fertility assessment. Certainly more and more recognized right now. The caveat is that we should only treat it if it's on the culture. We shouldn't treat it blindly, you know, because that can lead to resistance, antibiotic resistance and things like that.
Something that I'm very passionate about, antibiotic stewardship. So
exactly.
And this increasing resistance. It's scary, isn't it?
It is. And, you know, with the advent of the seminal microbiome, we are detecting, you know, a lot of commensals as well as, you know, pathogenic bacteria to sperm. So that the evidence isn't there yet for a lot of bacteria affecting sperm health. And there is a lot of contrary evidence with the microbiome. So it's about being very sensible. I mean, we our group of andrologists, I think we produced one of the first papers about the seminal microbiome.
We refer back to it.
I often send it to clients, actually.
And which bacteria, isn't it? You know, it's a big paper looking at all the evidence around the world at that point in time. And so there are groups of bacteria that are more harmful than others. And we do see this sometimes, don't we, where when we treat the infection, the semen parameters improve, the fragmentation improve. And sometimes that's all they need, to break through from a fertility front, either through IVF or natural fertility on the male side. So we do see this. So I think it is important, but it has to be taken in context.
In context, what their journey's been, as well as the results themselves.
Yeah, so I would hasten against taking a semen microgram, looking at the results, and then Googling for antibiotics, which is what unfortunately one of our patients did, and then they ended up with a massive issue because then it suppressed the immune system, and then they had massive oxidative stress issues, and then they had recurrent infections. And it was just a nightmare to unravel. We finally managed to we just stopped everything, and we went back to square one. And
because antibiotics, I always explain to my patients that, yes, they'll help to eradicate the infection or the bacteria that's causing the problems, but they're also going to cause a wider spread issue as well in terms of affecting the commensals.
That's right.
And the good bacteria that are there doing good things for us.
Absolutely, yeah.
So it's really, really important to not just jump straight to using antibiotics.
Yeah, and that's why I work very closely with fertility nutritionists, actually both of you, because it's the same with supplements, isn't it?
Yes.
It's the same with supplements.
Yeah.
In fact, most people are taking too much supplements, and they don't derive enough from diet and things like that. And it's just, it's easy. It's an easy fix. And I think it's the problem with male fertility, I guess, is that in the past with our patients, our male patients, were not given the agency to be able to, help themselves in a way. That's why fertility supplements are so tempting, because it's one way to think that, okay, I'm going to be doing something because my poor wife is going through all this. I need to be doing something. I've been told I'm okay. But actually, they probably haven't been assessed. And if you fully assessed, actually, lots of things that we probably need to do for you as well. And with supplements being one of them. And I think your work is very important because it's not just about nutrition. It's about the whole lifestyle modification side of things.
That's right.
Fertility issues are a lot to do with lifestyle and behaviors as well. You can be as fit as you can, but the context of your life is different, and it can be a very stressful life. So you can be working all the time, but there is this baseline of stress that can.
And I know we spoke about this before, didn't we? Because you test prolactin, and I know you mentioned a lot of your London patients. It's kind of through the roof, and we see it quite a bit as well. High prolactin, and so we're then talking to our clients and patients about their routines, how much exercise they're doing, are they overdoing it? Sometimes they're burning the candle at both ends, and actually they need to just pull things back. They think they're doing all the things to be healthy, like exercise. Maybe they're overdoing it, maybe they're overdoing the supplements, but they're not looking at the basics, the sleep, the foundational things that can make all the difference. And eating more colourful fruit and vegetables, these things can have a positive impact.
That's right. I mean, isolated high prolactin on its own, that the link with male fertility is still being investigated. But what it can do is it can affect your pituitary axis. It can affect LH, and
the signaling.
The signaling to testosterone production, which is important in sperm development. So if you have a pathologically high prolactin, sometimes it's indicative of a benign tumor, for example. So these are things we look at. But you're right. Most men don't have a pathologic high prolactin. It's very rare to have a very
It's a very sensitive marker, isn't it?
It is a sensitive marker, especially for stress. So
to environmental factors.
So it's very useful in a way to see, okay, I know what's going on.
And if it was something like a benign tumour, then it would be significantly raised. Whereas we see it quite just outside of the parameters.
That's right. We see it in a few hundreds, whereas a symptom tumour is usually 800, 900,000 and over.
So outside of varicocele, could you just explain to us about the impact of low testosterone?
Yeah.
And I think that's something that we're seeing a lot more now with even younger males.
So this can be a complicated topic, can be quite conflicting in evidence and things like that. But actually, it's quite straightforward. A low testosterone can have a big impact on fertility and other things, and the coital side I mentioned, erections and things like that. And but most people don't have a low testosterone. Most people don't have a low testosterone. Most people have a normal testosterone. Okay, so and we see this in our fertility practice as well. A low testosterone, however, can cause lots of problems because testosterone is one of the key hormones in sperm production, sperm maturation, development of the proteins for sperm, things like that. So it's a key driver of all these different things. So we do treat it when we find it, but we cannot give direct testosterone.
No, we can't. No.
Because that suppresses your body's own testosterone, and it's a very effective contraceptive.
It's what we call a negative feedback, isn't it? So it will, like you're saying, suppress
your own body's testosterone, and in effect makes you infertile. Okay, so this is one of the key issues in andrology work. Which is that men often don't get counseled for infertility when they are started on testosterone therapy.
Yeah.
Okay. Oftentimes unnecessarily. And this is a vogue right now.
Yes, it is.
I've heard people talk about it in the supermarket. Overheard men talking to their friends about taking testosterone or like checking their testosterone. Seems to be a bit of an obsession at the moment.
I mean, it's double-edged because yes, I think in the past we did not recognize the massive effects that testosterone can have.
The vitality, the energy, the focus, all of those.
Motivation.
But at the same time, it's partly because it is very profitable business.
Yes.
It's come the other way as well. So it's about balance, and every patient's a bit individual when they come through the door. But one thing that's for certain is we tell everyone to stop their TRT, because that's going to be the reason why they're infertile in a lot of the cases. But,
and will it reverse itself then if they stop their testosterone treatment? Okay.
Usually does, but not all the time. But in men who have genuinely low testosterone, which we see in the practice, then there are things you can do to raise the testosterone. For example, you can use estrogen antagonists and things like that. You can use anastrozole, letrozole. You can use Clomid, which is selective estrogen receptor modulator, they call it. Because it does different things essentially.
Yes,
You can use HCG, which is a synthetic version of the hormone that you produce from the brain to signal testosterone production in the testicle. So you can use all these things. We use a combination in our practice.
I just wanted to quickly ask one more question about something which I don't think there's a lot of research for, but thyroid dysfunction or suboptimal thyroid, like TSH, for example, being quite elevated but still within the normal range. Do you see yourself that impacting sperm?
So we do check thyroid function, but this is usually in the context of the hormone test, not in isolation. Again, there is no strong evidence that TSH alone, totally impacts on sperm, but it can affect it can be a marker that the axis is going wrong. Okay, so it's useful. It's useful to trigger other investigations, and definitely if your thyroid is extremely abnormal, if it's extremely high, extremely low, the systemic effects can affect sperm, and we would treat that as well. So it's something important to screen for, but it's not usually recognized as a primary hormonal cause of male fertility issues.
No, I mean, it is something I tend to look at because there are things that we can do nutritionally to try and help with, conversion of T4 to T3 and just to optimise that function essentially.
Yeah, and that's it. When I see thyroid dysfunction, I think one of the things I say it's very useful is to go and see you guys. Because oftentimes when after they've seen you, things correct. With nutrition, they don't have to take the thyroxine. Although sometimes we do start thyroxine, but most of the times we don't need to. They tend to correct.
I think what you've kind of mentioned throughout is that everything works together in the body. Nothing works in isolation, does it? Yeah. And so all of our hormones, that hormonal system is, like you were mentioning, the prolactin with the testosterone, the pituitary sensing everything in the body, and and again that thyroid function is part of that hormonal system as well, that endocrine system.
It's all linked, and that's why male fertility is such a great specialty. It's a bit like an art, because you have certain parts of the jigsaw that have a lot of evidence. Okay, this is great. There's certain parts of that have less evidence, and you think, okay, but how does this fit in with my patient? My patient has this kind of lifestyle, this kind of hormone pattern, this kind of sperm pattern, and this kind of fertility track record. I think that this is going to be really useful based on the evidence we have right now. And then you use that to create more evidence for the patients. That's what we've been doing. Every patient becomes a story in our big book of how to treat male fertility. And that's why it's important that we keep pushing that your job as well as ours keeps pushing the evidence to help patients.
I think I see it so just to kind of compare or give another analogy, I see it a lot in perimenopause and menopause as well. So we might run some bloods, but your bloods look absolutely fine, but then it's looking and marrying your test results with the symptoms. And you're saying that some parameters might have less evidence, but if the patient's still got those symptoms and they're presenting with something, then we can't say that just because your test results look absolutely fine, then nothing's going on, or it's really important to take that sort of detailed history and marry everything together.
I see this a lot because I run a national access clinic for Klinefelter syndrome, as XXY patients who have one of the biggest cohorts of patients in the whole world. Actually, they're amazing patients, and they unfortunately one of the most underserved populations in terms of overall care, because although they do have fertility issues, and that's how most of them get diagnosed, 70% of them, they have multi-system disease, and they are often treated as, okay, you need testosterone, and that's it, and their main concerns are often not addressed because of this. And part of the reason is because we never used to have the knowledge and the evidence that we could help. And actually, it's because we didn't do the research. And now that we are understanding the condition more and more, there are so many strands to it, neuropsychological, cardiac, respiratory, endocrine, of course, immunological. These guys have much higher risk of clots and things like that. So, do you start testosterone for all of them? So fascinating. And yes, that this is a key example.
And I think, you're singing from our hymn sheet because, as nutritional therapists, as functional medicine practitioners, that's the sort of essence of how we approach things. Like the body as a whole, it doesn't work in isolation like different systems. Unfortunately, our medical system is a little bit broken in terms of if you present with a symptom, you'll go and see a cardiologist, or then you'll go and see a gastroenterologist or an andrologist or something, but nothing is married up.
That's right.
But your approach is very much looking at everything. And you know, that's, I think, why we all get on so well together as well, you know, and work so well together, is because we take that same approach.
I think so. And every time I speak to you guys, to my colleagues, we end up spending much longer than we have time allotted, right? Because there's so much to talk about, there's so much to think about, and it's all for hopefully to benefit the patient.
And just to finish then, how do you see that integrative approach with nutritionists or other people you refer to alongside the work you do? How does it benefit your patients? Have you seen those improvements come through in those sort of retests?
Yeah, absolutely. You know, that's why I think you're integral to a good practice, you know, the fertility nutrition aspect, because I think it's a misnomer. Fertility nutrition, you don't just do fertility nutrition. You know, you help them with weight management, you help them with stress reduction, you help them with sleep, and you help them focus and keep the momentum going, because it's difficult, right? Because sometimes these journeys take months to years.
Exactly.
And you need someone there to just say, no, you're doing it right, you know, don't fall off for now, you know, and to make it somewhat enjoyable, right? You know, you recommend things like acupuncture and things like that, which help them relax, you know, help them through this journey. They might not ever go for fertility acupuncture again, you know, after the journey is through. But, you know, while they go through a journey, to make it an interesting couple journey, you know. And not all things have a direct impact on fertility, but they have a direct impact on their lifestyle. And that's important,
definitely.
you know. So it's about quality of life, you know.
Thank you so much, Professor Yap. I know you've got a very tight schedule, and we're so grateful for you coming here today and giving us your time, and our listeners are really going to benefit from this as well. So thank you very much.
Thank you so much. We will pop Professor Yap's details in the show notes, so if anyone's interested in or wants to explore male factor or their fertility in more detail, then we'll give all of the links and things to get in touch with you. We hope you liked this episode. Please like, subscribe and give us a follow over at Fertility Hormones and Hope on Instagram, and like I said, just check the show notes for further information as well.